that is fracture principles of management. Means how we manage, okay, or how we treat fractures. In the beginning, what we do later on, okay, and what are the different areas of fracture management. Before we go in the management, diagnosis of fracture has to be done. If you cannot diagnose the fracture, then how you are going to manage it, isn't it? So let's diagnose it first. And this is not new thing. We have already done this before. This is a bit of like revision for you. Clinical features and X-ray will give us the diagnosis. So what are the clinical features? Please, all of you focus here. Look on the screen, please. If some students get this question in the exam, they should feel themselves lucky. The clinical features, there is a history of trauma, okay, and that history of trauma can be a big type of trauma or injury, or a very trivial or a slight amount of injury. A slight or trivial type of injury can lead to fracture in pathological type of fracture. Remember that term. And if the bone is healthy, then we need a large amount of force to break it. So history of trauma is really important. We should ask this question all the time. What were you doing when that thing happened? Is it because of accident or something else? Regarding the symptoms and signs of fracture, pain and tenderness, probably the most important one. There is severe pain at the fracture site. And okay, when we press it, the patient complains of pain, that is tenderness. Sometimes, okay, pain is not that much, but tenderness is very pronounced. One of the example I like to highlight quickly here. Okay, let me write the name of the fracture here. That is called scaphoid fracture. Now, in scaphoid fracture, pain may not be there. Pain may be slight one, and patient may be ignoring that pain. But when I press at that bone, at that site, patient complains of more pain. So tenderness is an important feature in scaphoid fracture than the pain, and that tenderness will help us to do the X-ray. And very important point, in the beginning, X-ray doesn't show anything. It takes few days, okay, probably 7 to 10 days. Then only I can see the fracture line in scaphoid fracture. We'll talk about this later. After pain and tenderness, another important point is swelling. If there is a fracture, there will be swelling because there will be bleeding in that area. The fracture hematoma will be formed, and that leads to swelling. Deformity, especially if the fracture is displaced, deformity is very common. In displacement of the fracture, deformity is very common. Crepitus, when the fracture end moves, the upper end of the fracture, okay, the upper bone I should say, and the lower bone, when they scratch with each other, a typical type of sound is produced, that is called crepitus, or we can also feel it there. Loss of function is a very important feature. The function of that limb is lost after fracture. What does that mean? In the upper limb fracture, okay, we cannot grip now. Okay, we cannot use our upper limb when the fracture doesn't heal, till the fracture doesn't heal. And in the lower limb fracture, we cannot walk. Another important point, nerve and vascular injury are very commonly occur in the fracture. That's why you should know in detail about the nerve, from where it originates, what is the pathway, what are the branches, what muscles are supplied by that nerve, and what happens if that nerve is damaged. Similarly, blood vessels, what are the major arterial circulation there, what are the major vein. So these are very, very important points. Now all of you, please have a look at this slide. What can you see here? Yes, What can you see here?
Swelling on the joints.
Deformity.
Very good.
Swelling.
Deformity in the joints.
Very good. Both
Swelling.
swelling as well as deformity, both are seen. Excellent. Swelling and deformity. Now this is a wrist joint. This is a wrist joint area. Okay. Now see there. This is the forearm. There is the hand, and this is the wrist joint area. So most probably this patient has developed fracture around the wrist joint. As a result of this, there is a deviation of the hand, okay, deviation of the hand towards the thumb. So this is a thumb here. So towards the thumb, there is radius bone. So deviation of the hand towards the radius bone, called radial deviation. This is a type of deformity. And at the same time, I can see swelling here. A bit of redness, okay, is also seen here on the other side. Now, to confirm fracture, we have to take X-ray. Even without X-ray, we know that bone is fractured, but X-ray is taken 100% of the time, because I need to exactly look where is the X-ray, sorry, where is the fracture occurred, okay, what is happening to the upper fragment, what is happening to the lower fragment, okay, how bad is the fracture, everything, all information will be provided by X-ray. Now there are certain rules of X-ray. Now let's talk about that rule. That rule says we should take two sides X-ray, that is bilateral, which many of us won't do in the hospital. Let's talk practically. Many of us won't take X-ray of the normal bone, means of the opposite side. But if you take, you can always compare what abnormality has occurred in the fracture site. Okay, that is rule 1. Second, two views are important, and they are AP view and the lateral view. We take this 100% of the time. All the time these two views are taken. Two joints should be included from the fracture site, that is joint above and joint below. Another important point, joint above and joint below. If you do not do that, sometimes there may be a small fracture which has occurred right below the joint, and we'd miss that. Another one, X-ray should be taken before the reduction and after the reduction. Now reduction is a type of treatment of fracture. Okay, those bony fragments which are displaced away, we should bring them together, and after that we take the X-ray again to make it sure whether they have come back to their original position or not. So before, we need to take it for the diagnosis. After the reduction, we have to take it again to make sure whether they are properly reduced or not. So these all are X-ray rule. They are called rule of twos. See there, okay, because of this reason. Some special views can be requested. It depends on the circumstances. Now CT scan and MRI can be taken. Now these days, let's talk about China, where we are studying right now. Our university is there, and these days in Chinese hospital they directly take CT scan. They don't like to take X-ray. Okay, so CT is very commonly done in any type of fracture or any type of soft tissue injury. They love to go for CT, or for soft tissue, if it is a major main soft tissue injury rather than bony injury, they can go for MRI also. MRI, it is not helpful in fracture diagnosis other than delineating associated injury to the central nervous system, subtrochanteric disruption, or occasionally fatigue fracture. So only for these 2 or 3 important indication you go for MRI. Other than that, CT scan is routinely done rather than MRI. And you know this principle. For bony diseases, CT is preferred than MRI. For soft tissue injury, MRI is preferred than the CT. Now, this is a very important slide. it tells us everything regarding the management of the fracture. Now, this is a introductory slide for you, and the whole class, okay, later on is all about this. So how we start managing the fracture, what we do in the beginning, and later on what should be done. See here, first is a first aid treatment. This first aid should be started right from the site of injury. Right from there, the treatment should be started. So, airway clearance and maintenance of breathing, it is not needed in all type of fracture. Okay, for example, there is a Colles fracture. Why should you maintain the airway, isn't it? Only that bone is fractured, nothing else. Patient doesn't have any other injury. So this type of discussion is not necessary there. But at the same time, if the patient suffers road traffic accident, many different areas of the body can be damaged. Who knows? The patient may be having head injury. Patient may have cervical vertebra fracture. Patient may be having pneumothorax because of the rib fracture. So airway and breathing has to be examined in serious type of fractures. Another is control of external hemorrhage. If there is brisk hemorrhage going on, okay, we should control it. Especially it is very common in compound or open type of fracture. Cover the external wound with a clean dressing. This is important one. Don't allow any dirty things, okay, to come in contact with the wound. Cover it with a clean dressing till you take the patient to the hospital. Immediate immobilization is done. Now, how to do the immobilization? If okay, if it, of course, many of the fracture occurs outside the hospital. Okay, that's what I'm talking right now. At home also, or maybe somewhere else outside. So what we do to immobilize that fracture site? This is called splint. Okay, certain splint has to be applied there. That splint can be of anything. It can be a piece of wood. It can be a piece of furniture. It can be some hard object there. Okay, any stick also can be applicable. It can be a hard board, for example. You should keep it there and then, okay, tie it very gently so that the fracture site is not mobile anymore. It has a lot of advantages. Number one, it will relieve the pain. When we move that fracture site, there will be severe pain. When we do not move, it will decrease the pain. First. Second, it will also decrease the chance of vascular and neural injury. That vascular and neural injury is more common if fracture site is moved. Bleeding is also controlled if it is not moved. Okay, a lot of important advantages are there. And then relief of pain. So quickly, patient should be given some analgesics because fracture is a very painful condition. Okay, so you don't wait. Some of the people think no, it will be difficult for the doctor to diagnose, so let's not give any analgesic right now till the doctor examines. Nothing like that. Fracture diagnosis is very simple, so you don't need to wait for that. Okay, so give analgesics right there and relieve the pain. Second important general principle of fracture management is clinical assessment in the hospital. That is done by the doctors now. State of circulation, what about the pulse and what about the blood pressure? Check the vital signs quickly. If pulse, okay, is within the normal range, I mean the rate of the pulse, if the strength of the pulse is good, if the blood pressure is within normal limit, probably this person is not in hypovolemic shock. So this is very important information. Another one, check the pulse in the distal area of the fracture. If the volume of the pulse is still good there, probably blood vessel injury has not happened. So this is important knowledge. Another one, check for the state of consciousness. See here, this is done by Glasgow Coma Scale. Now, this is not a new thing for you. So, what are the parts of Glasgow Coma Scale? Anyone?
Eye, mouth,
Verbal.
Okay, okay. Then,
eye, mouth,
Eyes. Eyes.
then,
Visual, verbal,
and
verbal, motor, and
conscious.
visual. We
Motor.
check the consciousness of the patient by
good,
this
Motor.
Glasgow
Visual.
Coma scale.
Verbal.
good. Now
So,
I got your answer. Very good. Most of the students, though they have not exactly told me what we should do, but those type of answer will work. You need to do a bit of revision here. It has got three important component. Eye opening, it is known as E, eye opening, okay, verbal response and motor response. Eye opening, verbal response and motor response. These three are important features of Glasgow Coma scale. Each of them has got different score there. And what is the maximum score?
15.
15.
15,
Minimum 3.
Very good.
minimum 3, maximum 15.
Minimum 3.
Very good. Minimum is 3, maximum is 15. Excellent. Okay. So one more important point here. If Glasgow Coma scale is less than 8, we believe the patient is in coma. Glasgow Coma scale less than 8 is equivalent to comatose patient. These days, this Glasgow Coma scale is relatively cumbersome or difficult to do, or it takes a bit of long time. That's why another scale they have devised, and that is called AVPU scale. So let me write that for you. AVPU scale. Now, there's a very simple meaning. A means alert patient. Okay, patient is all right. Glasgow Coma scale is probably near to 14 to 15. V, patient is only responding to the verbal command. He's drowsy. We should call him by his name or shout at him probably. Then only the patient will respond. P, only responding to painful sensation. So you have to give painful sensation to the patient. Then only he will open the eye probably. And U means unresponsive. It is equivalent to coma. AVPU scale, very important one from the clinical point of view. But Glasgow Coma scale is still very commonly done in case of head injury. Remember that. Let's move on. Another is identification of any communicating wound, if it is there or not. Now, communicating wound, okay, is also known as compound fracture. That's what we are talking right now. If compound fracture is there, and if we have failed to identify it, there is a high chance of infection in that particular site. So a surgeon, orthopedic surgeon I mean, or the general doctor who is treating this patient for the first time in emergency department, they have to properly look at that fracture site and see for any wound is there which is communicating to outside or not. If it is there, proper debridement has to be done. Another one, look for the evidence of vascular, nervous or visceral injury. Now, vascular injury, we already talked about. Check for the pulse. How strong is the pulse distal to the fracture site? What about the capillary refill time there? What about the temperature there? Is the patient complaining pain on the distal side of fracture or not? Is the patient complaining of loss of sensation there or not? These all are feature of blood vessel injury. Nervous injury. What about the sensation again? Is there dysfunction of the muscle contraction or not? Can the patient feel the sensation or not? This is motor as well as sensory nerve injury. Now, visceral injury is the internal organ. Okay, in limb it is not very important, but in the body it is important. Like in rib fracture, injury to the lung, in sternal fracture, injury to the pericardium, or even to the heart. This is very important point. Fracture of the skull, high chance of injury to our brain. Fracture of the facial bone, okay, there is damage to the internal structure now. Fracture of the pelvis, there is high chance of damage of the pelvic organ. So these are good examples. So these are the clinical assessment. Now let's move on to the specific treatment of the fracture. Now what are these? First of all, we should reduce the fracture. Now this is an introductory class, so all of you please listen, okay? Make your concept, and later on the understanding will be very easy for you. In the beginning, we reduce the fracture. Now reduction is not necessary for all the fracture. For example, some of the fracture, there is very nice transverse fracture without any displacement of the segment. Why should we reduce it? There is no need. Another one, okay, flat bone fracture. They are not moving usually. They remain in their own place until and unless it is a depressed type of fracture in case of skull. Okay, that's a different thing. So reduction is not necessary in every type of fracture, but it is necessary if there is displacement. Reduction can be done by two ways: closed reduction or open reduction. Now closed reduction means you don't do any surgery there, you don't give any incision, you manipulate it under anesthesia but closely. So what does that mean? We give painkiller to the patient. Maybe we give ketamine. Now what is ketamine? Ketamine means what? Anyone? Have you heard this drug before? I'm sure you have.
General anesthetic drug.
Very good.
Anesthesia.
This is general anesthetic drug. Yes, general anesthetic drug. And this drug is very commonly used in the treatment of fracture. During the fracture reduction, this is a very painful procedure. So they give ketamine. Patient will be unconscious for certain duration. They maintain the airway, breathing, circulation, everything during that time. Quickly, fracture is reduced, okay, and it is treated. Ketamine, remember that, very important drug. Now, open reduction is by surgery. This is called open reduction followed by internal fixation. So usually open reduction is followed by some sort of internal fixation. Second important principle of specific treatment of fracture is immobilization. Now this is necessary in every type of fracture. This is probably the most important point in fracture healing. We have to immobilize the fracture, otherwise fracture is not going to heal in time. Again, flat bone fracture, okay, they don't move that much, so patients can move here and there. For example, skull bone fracture, a rib fracture, okay, patient can work normally. They just have pain. There is no real chance of decreased healing there. But what about our limb fracture, upper limb fracture, lower limb fracture? We must immobilize them properly, otherwise they don't heal. Third, rehabilitation. The point of physiotherapy comes here. Fracture is healed, patient start to walk, but in the beginning, okay, patient feels very awkwardness in that joint, in that fracture site, because it is inside the plaster of Paris for a long time. Probably some surgical instruments or some surgical device are kept there inside. So we should teach that patient how to do exercise, how to do physiotherapy for certain duration. Then only patient will regain the function. This is called rehabilitation. So never forget the importance of rehabilitation in the treatment of fracture. Now, along with this, some supplementary treatments are also necessary. So what are these? See there, analgesics, always necessary. IV fluid, necessary in most of the time, especially if we suspect bleeding has happened or large amount of bleeding has happened. IV fluids are given. Antibiotics only necessary in open or compound fracture. In closed fracture, you don't need to give any antibiotic because there is no chance of contamination or infection. Don't forget to give prophylaxis against tetanus. This is again important if there is a cut or external injury or compound fracture. We give tetanus toxoid all the time. Now, I'm not sure whether you know this or not. So, when should we give tetanus toxoid? Should we give tetanus toxoid to all the patient or not? Yes?
No,
No, sir.
no, sir.
Injury
If the
patient.
wound, open and
Only injury
chronic
patient.
Open,
Go.
If the
open
wound
is
is dirty,
fracture.
the wound is
Open.
dirty,
Open
and take the
or
Open
dirty.
fix.
If the wound is dirty, then we will give.
Good. So, very important answer you have given. Excellent. So, you are saying not necessary in all type of fracture. Very good. If it is a closed fracture, we don't give tetanus toxoid. It is very, very essential in open or compound fracture. Now, let me share some important knowledge right here with TT. If the wound looks very dirty, if there is a lot of contamination at the wound, okay, and if the patient has not taken any tetanus toxoid injection from the last 5 years, I will give TT. But if patient has taken tetanus toxoid in the last 5 years and before that they have already taken the 3 doses of TT, these 3 doses are given according to EPI schedule. We all know that they are given at 6 week, 10 week, and 14 week of birth. Okay, we believe the patient has already taken them. Okay, 3 doses are done. Because of something, patient has taken one more dose. Okay, and it is still later than 5 years. Probably, if the wound is not very dirty, or if it is a clean looking wound, you don't need to give TT. But any type of doubt or slightest amount of a communication with the patient, or patient forget about when they took TT, to be on the safe side, just give tetanus toxoid injection. That is always safe rather than become overconfident and not giving it. Now, regarding the prophylaxis of gas gangrene, okay, what can we do there? Anybody? What can I do?
Imputation. Input.
Okay.
Imputation.
Antibiotic.
Okay. Now this is prophylaxis, right? This is prophylaxis. Remember, this is not the treatment I'm asking. For the treatment, yes, you can answer amputation, okay, and all those different types of treatment like debridement and all those things. But for the prophylaxis, proper cleaning of the wound is necessary. Okay, proper debridement of the wound right after the injury is necessary, and antibiotic prophylaxis may be necessary. So these are some of the important points. Now, regarding the fracture principles of management of fracture, we already talked about the diagnosis, okay, and how we make a diagnosis of fracture. Can anybody tell me just in 2 lines how a fracture diagnosis is done? Yes?
On the basis of clinical feature and X-ray, sir.
Very good. Excellent. Okay, those are the 2 points I want. Because of the basis of clinical features and X-ray. Now, clinical features are so obvious in any fracture. There is pain, there is swelling, there is deformity, there is loss of function. Okay, all these things are very typical. And at the same time, we do X-ray. Now, there are certain rules of the X-ray. You have to take AP view and lateral view. Never forget it. You have to include joint above and below, and you have to always compare with the normal side. These are the absolutely important point. Second important principle is resuscitation. Resuscitation means if there is severe bleeding, okay, if there is for example a fracture of cervical vertebra, there is a high chance of injury to the airway as well as problem with the breathing. So for this, we always say, according to the advanced trauma life support, it is A, B, C, D, and E. Now, D and E we'll talk about later, but A, B, and C are very, very necessary for the students to know right now. A is airway management, B is breathing, and C is circulation. So this is all comes under resuscitation. And then this topic is all about the management of the fracture now. See here, how to do reduction, how to maintain the reduction, and how to do rehabilitation. Now, these are the things which we are going to talk in today's class. Let's move on. Now, before I go into the reduction, let's talk about how to manage open fracture or compound fracture. This is known as orthopedic emergency. So we should never ignore open fracture. Now, can you tell me why it is considered as orthopedic emergency? Can you give me one or two reasons? Yes?
Sir, due to spread of infection.
Good, very good. One is
high chance of hypovolemic shock,
Bleeding.
of infection now,
good,
high chance of tetanus.
very good. I already got the answer here. Okay, excellent. Now see here, so students clearly told me there is a high chance of infection because the wound is communicating outside. Number one. And number two, there is high chance of excessive hemorrhage. There is high chance of hypovolemic, volemic shock or hemorrhagic shock in this condition. And another one also you can add, there is high chance of damage to the nerve, blood vessel, or other important structure there. So that's why it is considered as orthopedic emergency. Now what does that mean? Even if the patient comes at middle of the night, okay, if there are no surgeons available at that time in the hospital, the on-duty doctor should call the orthopedic surgeon right at the middle of the night. We don't care about what is the time there. The surgeon should come, should attend the patient and do whatever is necessary. This is known as emergency. You cannot give antibiotic and say, oh, the doctor will come next morning and he will deal with this. That is not, okay? Emergency means it has to be dealt right now. The most important consideration when dealing with an open fracture is to reduce the risk of infection. If we delay the treatment, there is high chance of infection. That's why we need to do it right now. And what type of infection we are talking about? It's osteomyelitis. In the beginning, acute osteomyelitis, later on, chronic osteomyelitis. And chronic osteomyelitis is a very difficult condition to treat. It may lead to non-union or delayed union of the fracture. And if you remember in the previous classes, we talked about that. It's a very difficult type of management. Patient will suffer a lot. And why the patient has suffered? Because our management was not proper right in the beginning. Okay, this is what we are talking right now. The sepsis is best prevented by early and aggressive cleaning of the wound. Early and aggressive cleaning of the wound with excision of dead tissue and all the foreign material should be removed. This is called debridement. See there, what may happen? There may be a severe type of injury. The muscles may be crushed there. The bone pieces may be separated, isn't it? They may be coming outside the wound. So what we need to do, we need to give a good incision there. We need to remove all the dead and devitalized tissue. Now devitalize means the tissue which has lost its blood supply, or sometimes it's already dead also. We need to remove all those tissues. Sometimes there may be some foreign body there. We need to remove those foreign body also. This process is known as debridement. Very important term in surgery. See there, this is debridement. Okay, if somebody asks you what is the meaning, just say cleaning the wound thoroughly and removing any dead and devitalized tissue is known as debridement. It is absolutely necessary, okay, to prevent from the secondary infection to occur and to prevent from some dangerous complication to occur. Let's move on. Okay. Now see there. Now you already know about the concept of debridement. Now what should we do to that wound now? Because probably some big part of the tissues is lost. The wound is widely open. So should we close the wound or not? So what do you think? Should I close the wound at the time of debridement or not? Yes?
Not.
No, sir. If infection is there, I'll leave it open.
Very good. Very
The
good.
infection occur.
Excellent. In surgery, remember in surgery, in general surgery discussion also, I told you very clearly about this. Whenever the wound looks very, very bad, okay, contaminated wound, you clean it thoroughly, you do the debridement and leave the wound open. Do not close it right now. That is such an important point, because there is high chance of sepsis development if I close the wound right there. So it needs to be opened. You cover it with a sterile dressing. That is always done, because this is not the closure of the wound, isn't it? We just cover it with a sterile dressing, and next time when I want to examine the wound, I can easily remove it and examine and do the necessary treatment. Now, in some occasion, primary closure is desirable, okay, if it can be achieved safely. Okay. For example, if the patient has come to the hospital in less than 6 hours after the injury, if the soft tissue damage is minimal, not that massive, and if the degree of contamination is also not that much, then probably I can close it. Okay, but some situation has to be there. If you are in doubt, okay, don't close it. Opening the wound is much safer option than closing it. Now, if this philosophy is followed, then each case is judged on its merit. Means all the wounds cannot be closed and all the wounds cannot be opened also. It depends on some of the points. That's what we have discussed right now. Generally, leaving the wound for secondary closure and skin cover is safer. If you are in doubt, always choose this option. Now, this is open wound, okay, severe type of contaminated wound. So antibiotics are the must, and they should always be given after you take swab from the wound. Don't forget that this is the standard, procedure for us. And some of the surgeons, they believe I've already given the antibiotics, so why to take the swab for culture? Okay, that is not the way we think, because who knows, the antibiotics we are giving cover the microbes. It may not cover, and if I have not taken any swab for the culture, so there will be no growth of the bacteria, and I cannot do any sensitivity test. So these are the very important point. Okay, now which type of antibiotic you give? Yes, I want to hear some answer here. Which type of antibiotics?
Aminoglycoside.
Broad spectrum antibiotics.
Broad spectrum antibiotics.
Third generation cephalosporin.
Gentamicin.
Very good. Okay, now already got the answer. Excellent. Okay, you guys are developing the concept already. These are broad spectrum antibiotic. So you have to cover all the important organisms like gram positive organisms, gram negative organisms, and anaerobe organisms. All of these should be covered. So probably a combination of antibiotics should be given. Okay, a good choice for us, would be probably, okay, different combinations. Some of the surgeons may give penicillin, okay, to cover the gram positive. Penicillin here, one aminoglycoside, probably amikacin or gentamicin, and to cover the anaerobe you can give metronidazole or clindamycin. This is one of the very good combination. If you do not want to use penicillin, you can also go for cephalosporin, a third generation like ceftriaxone, which is a very good drug for both gram positive as well as gram negative. It has more coverage for gram negative, but don't forget it has coverage for gram positive also. Along with that, okay, to have a more gram negative coverage, some of them are adding amikacin here also. But if you are quite certain that ceftriaxone will cover those gram negatives, you don't need to add amikacin. So this is the decision of the doctor there. And metro again. So this is one of the example. If primary closure is not considered appropriate in the beginning, every attempt should be made to close the wound within 72 hours. Okay. Now, by that time, the infection must have been settled. So, okay, so there is no further risk of infection. So we can close the wound. Okay, after 72 hours means after 3 days. Now, let's talk about something more regarding the open fractures. Closure is usually achieved by one of the methods of skin graft. Okay, that skin graft, okay, should be in combination with a tissue flap, because that bone, okay, that fracture site should receive a good blood supply. And sometimes because of a severe injury, the blood supply was already lost. So only doing split skin grafting may not be enough. We need to go for tissue flap type of graft. Okay, so this is important point. And when we do this type of thing, we should always involve plastic surgeons, because plastic surgery is the field of surgery which is concerned with this type of grafting. So orthopedic surgeon should take the help of plastic surgeons when they are thinking about closing the wound, because grafting is very much essential. Now with this, a discussion about open fracture, which is one of the important orthopedic emergency, let's talk about the important part of today's class, that is reduction. Now see here, the first thing we need to know is, does the fracture need reduction or not? Because all fracture will not need reduction. Now let me explain you by giving few example immediately. If it is a very nice type of transverse fracture with no displacement of the bone, then why you need reduction, isn't it? That is one good answer you can give. And another one, usually fracture of the flat bone, okay, fracture of the flat bone, they don't need any reduction. Reduction is not necessary there. So remember always, all the fracture do not always need reduction, but it may be necessary for the following reason. Now let's talk about those reasons now. To maintain function, see here, to maintain function of that fractured part, if the fracture is left to unite in the displaced position, often there will be functional impairment such as a short limb. For example, a distal fragment, okay, is moving proximally, and if I has not reduced properly, the fracture may unite from the sideway, okay, part, so that there will be short limb after the healing. This is not desirable. That's why we need to do proper reduction. In general, fractures involving joints require anatomical reduction if possible. Otherwise, the functional loss of the joint will happen. With fracture of the shaft of the radius and ulna, malalignment is likely to cause restriction of pronation and supination. Now see this, malalignment is likely to cause restriction of pronation and supination, especially in the fracture of radius and ulna. Now every student know the meaning of pronation and supination. These are the anatomical term. These are the functions, okay, of our forearm, isn't it? So if those bones are not healed properly, if there is a slight amount of malalignment, then that particular function is lost, and that is a severe functional loss. Another one, if the limbs are not well aligned, then over a long period of time there is risk of osteoarthritis. This osteoarthritis is known as degenerative disease of the joint, and this occurs because of abnormal loading at the joints. This is a very late complication, okay? This is not the early, but it can happen if fracture is not reduced properly in time. Let's move on. Now, another point why we need reduction is for early mobilization. For some fracture, in elderly patient particularly, prolonged immobility in traction is really dangerous. Now, can you tell me why prolonged immobility in traction is dangerous? Why? What is the complication associated with this? Anyone?
If it is lower limit, it will lead to the deep vein
Deep
thrombosis.
vein thrombosis.
Very good. Excellent. Excellent. That's the answer I want. Very good. So there is a high chance of deep vein thrombosis, and after that pulmonary embolism, and pulmonary embolism can kill the patient. So prolonged immobility in traction is not preferred. So just think about it. The patient has come with a very bad fracture. You have reduced the fracture quickly. Okay, fracture has healed in time. Patient can mobilize early. And one more point, open reduction and internal fixation is always better than close reduction and external fixation, because that open reduction and internal fixation makes the fracture heals, okay, earlier than the other type of management. Third reason for the union, see this, some fracture unite with difficulty, usually because of impaired blood supply. Impaired blood supply that can happen because of the fracture, because of the injury to the blood vessels. If that happened, then fractures do not heal properly. But if we reduce it quite early, before the injury to the blood vessels occur, then there is no chance of impairment of the blood supply in the fracture site. So there is a high chance of better union. This is the point. So accurate reduction has to be done in time so that there is a high chance of union of the fracture. Another reason for the proper reduction would be to prevent neurovascular compromise. That's what I am talking right now. Think of a situation, bad type of fracture, okay, there is a very sharp edge of the fractured bone. That fractured bone can itself damage the nerve and blood vessel, and sometimes what happens, some of the soft tissue may be impacted between the fractured bone. So if we do proper reduction, then that type of injury will not occur commonly. That is the point. Another one is for cosmesis. Okay, cosmesis means it will look better if we do proper reduction. If we do not reduce the fracture properly, then it may unite or it may heal, but it may still leave some deformity because of some overlapping, and that is not acceptable for many people. So for cosmesis, or to look better after the healing, also proper reduction is necessary. So these are the different reasons. If your teacher asks why reduction is essential, why should fracture be reduced, these are the reasons you can give. Now after this, let's talk about what are the techniques of reduction, how we do it. Okay, so listen this class nicely, because I'm sure many of the students, even after graduating from the MBBS level, they can work in some remote area in the field of orthopedics. You don't need to be orthopedic surgeon to do these type of things. Okay, so this is a very, very important practical point for us. The first thing is manipulation under anesthesia, MUA we say, manipulation under anesthesia, MUA in the short form. This is the method adopted for most fracture and dislocation. Now, what do you mean by that? We give certain anesthetic for the patient. Now, can you tell me which type of anesthesia are preferred here? Yes?
General anesthetic, ketamine.
Good.
GI.
Okay, one is ketamine. What about the local anesthetic? You don't want to give local anesthetic?
Lidocaine.
Good. Lidocaine, yes. Lidocaine is usually given. So let me elaborate on this a little bit because it's important point. One of the mostly used drug, okay, is ketamine. Very, very commonly used drug all over the world. But for ketamine, you need to have IV line. IV line is necessary there. And sometimes, you know, ketamine is a safe drug. Okay, I'm not saying that, but sometimes that ketamine may result in respiratory depression, a respiratory arrest. So whenever you give general anesthesia, make sure your resuscitation kit is very nearby. And resuscitation kit means it has everything. When the patient, needs it, for example, it has got endotracheal tube here, different sizes. It has got adrenaline, atropine, okay, lidocaine, sodium bicarbonate, glucose, this type of drugs. It has got ambu bag, and all those things should be there. Always, any type of general anesthesia you give, remember this, do not take it lightly. Sometimes, if you are unfortunate, the patient which you are dealing with will suffer from respiratory depression because of ketamine. Okay. Now, after general anesthesia, local anesthesia is also very commonly used. Now, local anesthetic are very safe. Okay, they are very safe, but you need to remember one thing. Before you injecting local anesthesia to a particular site, what should you do? Anybody can tell me how you give injection of local anesthesia in that site? Any precaution you need to take? Anyone?
Give slowly.
Okay, give it slowly. Okay, 1 point. Any other?
Use vasoconstrictor.
Different point around the wood.
Okay, now see there.
Many points at many.
Okay, so you should give to a many point around the wound. Very good. That is another point. Okay, but remember, this is a very, very important practical knowledge for you. Whenever you give any injection, not only the local anesthesia, any injection in the body, you should always, okay, you should always aspirate it first before pushing the drug. Always aspirate it before pushing the drug, because you are not giving this drug inside the vein. Okay, this is not an intravenous type of injection. This is probably intramuscular or in the subcutaneous space. You don't give it inside the vein. So how you know I am not inside the vein? That is done by aspiration. If no blood comes when I aspirate, I'm sure it is not inside the blood vessel, then it is quite safe to push the drug. Now, why I'm doing it? If I push a good amount of lidocaine into the blood vessel, the person will suffer from seizure. So make sure you are not into the blood vessel before pushing the lidocaine. Okay, remember this all the time. You should develop this habit whenever you give injection. Now, sometimes lidocaine is given around the fracture site, and sometimes it is given regionally. Now, regional means if there is a upper limb fracture, I will give lidocaine to block the brachial plexus. I can do that. If brachial plexus is blocked, the whole upper limb will be anesthetized. So similarly, in the lower limb also, we can do the same thing. So these are the different points. Second thing is traction. Now, see here, what do you mean by this? Some fracture and dislocation may be reduced slowly by the traction. And this is usually used when manipulation is inappropriate. Perhaps because an anesthetic would be dangerous, like subluxation or dislocation of the cervical spine. Okay. Now, this in cervical spine injury, okay, anesthetic would be dangerous. There are multiple reasons we can give here. Local anesthetic, where to give? Okay, there is no proper space to give local anesthesia here. Regarding the general also, if there is already, damage of the phrenic nerve and paralysis of the diaphragm, which is very likely here, giving these, general anesthetics may be quite risky in this type of situations. So to reduce this type of fracture, some tractions would be used. Now traction means you keep on giving some pulling force in that particular area. Okay, that pulling force will reduce the fracture by itself over a period of time. This is called traction. Now the third is open reduction. Now open reduction, the meaning itself is very clear. This has the advantage of allowing very accurate reduction, but there is a chance of infection because you are opening that area, you are giving incision there. It's a type of surgery. If your surgery is not aseptic, if you have not properly sterilized all the instrument, there is a chance of infection. Usually open reduction is reserved for those cases where closed method will not give the desired reduction, or where internal fixation is going to be needed for some other reason. Now there are so many examples we can give here. If internal fixation is necessary for the healing, okay, of the fracture, then definitely we go for open reduction. Without giving incision there, how can I fix, okay, some of the instrument like screws, like plate, like rod? These are the examples of internal fixation. So open reduction is very much essential for internal fixation. Open reduction does not necessarily imply internal fixation, although usually it does. Sometimes you don't need internal fixation, okay, after open reduction. If you don't need to put any instrument or any device there, okay, you can simply do open reduction, fix the fracture, and then close it. Another techniques of reduction would be close reduction and fixation. Close, you are not opening that fracture site, okay, but at the same time you are reducing the fracture and fixing it. Good examples are intramedullary nail and external fixator. Intramedullary nail and external fixator. We are going to talk about them in this topic. Okay, this is a relatively longer topic, so there are different way of internal fixation would be dealt, and sometimes we fix the fracture from outside also, which is known as external fixation. And intramedullary nail means, okay, you give a very small incision, you do not completely open the fracture site, you don't do that. Probably an incision is given away from the fracture site, and then you insert a good length of the nail or the rod inside the medullary cavity. This is known as intramedullary nailing, very commonly done in fracture shaft of the femur and fracture shaft of the humerus. Now, after you reduce the fracture, the next step for us in the management of fracture is maintenance of the fracture reduction. We need to maintain it. If the patient keep on moving that fracture site, okay, or if we do not fix it properly, then fracture will not heal. So maintenance of the fracture reduction is also very much essential. Now how we do it? Have a look here. The stability is achieved by one of the following technique, and these are intrinsic stability, external splintage, and internal fixation. So intrinsic stability means some of the fracture they require no additional stabilization, like fracture pelvis, maybe fracture of the rib, fracture of the skull bone. Okay, these are flat bone, there's not much muscle attached there, so there will be no displacement of the fracture, so we don't need to probably do anything. These are called intrinsic stable fracture. Another is external splintage. The plaster of Paris is the perfect example there. It is all very commonly known as POP. Okay, and another one is internal fixation. The good example, I've just gave you some screws, okay, some nail, some plate. So all these are different points. Let's talk about external splintage now. Okay. External splintage means, okay, we immobilize the fracture from outside. Okay, please mute yourself. We immobilize the fracture from outside. Now, what are the different way of doing it? Many fractures can be adequately immobilized with a simple device, which you can see here. Okay, which you can see here in the picture. That a device or the splint may be made up of wire. It may be made up of metal or polythene, or it may be of sling or crutches. Now, quickly, let's have a look at this, picture. Here, there is a folded newspaper which can be used, okay, as a splint. Here is a foot rule which can be tied at the fracture site so that it can act as a splint. A pillow can also be used. If nothing is available, we can use this type of things. A wooden plank can be used, very good way of splinting. A bamboo, okay, a bamboo stick can be used. An umbrella also can be used if nothing is available. And this is called sling. This is sling, okay. This is called sling. This is another example of sling, which is called triangular sling because of the appearance. Now, a student must understand what is the purpose of using this splintage or sling here. And there are a few important purposes of this. One of the most important is to relieve the pain which occur at the time of fracture or after that. If we do not move the fracture site, the pain will be drastically reduced. Okay, and another one, to secure the immobilization, because if the patient continue to move the fracture site, there is high chance of bleeding, there is high chance of damage to the blood vessel, nerve, or other important structure. Now see here. Now, these are the important reasons for splinting. Few of them I've already talked. One is pain control. Definitely, if you do not move that fracture site, there will be decreased pain. It reduces further damage to vessels, nerves, and skin. Very easy to understand, because the number one or the most common cause of damage to this neurovascular structure is the fracture end of the bone itself. So if you do not move that site, then the damage would be less. Third, it decreases the risk of inadvertently converting closed to open fracture. Now, this can happen because of the rupture of the skin or because of the damage of the skin which is lying, okay, on the surface, which is lying over the fracture site. If that skin is damaged or open, then the closed fracture will convert into open fracture, and by doing splinting we can prevent it. Another important reason is it facilitates the patient transport also. Whenever we transport the patient to the hospital or any facilitating center, we have to splint the fracture site, and these are the different way of splinting. Let us see once again. This is a wooden plank. You can simply keep this, okay, on the fracture site and tie it on the both end. This is a Kramer wire splint. This is called Thomas splint. This is an inflatable splint, and this is called head halter sling. Okay, this is a type of sling. So the common concept you need to get is whatever is available, okay, near to that area, you can use that as a splint. The most important point is do not move the fracture site. That is really necessary. Now, what else? Another important way of immobilizing a fracture is casting, okay, with the help of a cast. And one of the important way how do we cast or make a cast is plaster of Paris, POP, okay, plaster of Paris. It is very widely used for making open or close cast, jointed cast, or even the splint. Now, jointed cast is used, if a fracture occur around the joint, because we want to mobilize the joint. At the same time, you want to immobilize the fracture site. So for that purpose, jointed cast would be used. We'll talk about that later. Now, quickly have a look at this picture here. See here, this is the plaster of Paris. Okay, it will come like this as a roll. You quickly soak it in the water and then apply nicely. Okay, apply nicely like this. After some time, this, okay, will get harder. Okay, it will get organized there, and then it is very difficult, okay, to bend or to remove. Also, we need to cut it to remove, and this acts like a splinting effect from outside. So this is called cast. Sometimes if you don't want to put a cast means all around. Have a look here. It is all around the fracture site, isn't it? But sometimes we just put this plaster of Paris on one side only, not everywhere, not like a rounded one. This is called slab. Okay, slab. Sometimes a slab may be necessary, okay, rather than the cast. Now let's move further. What are the advantages and disadvantages of plaster of Paris cast? Now see here, the advantages of plaster of Paris would be it is quite cheap and easily available everywhere. Okay, it can be bought everywhere. Wherever the fracture occurs, it can be bought and used in the patient. Second, it is versatile and readily applied and fashioned according to our need. You just need to see it once or twice, after that you can use it by yourself. It is not very difficult at all. It is reasonably comfortable, though there are some discomfort associated with it. Okay, we'll talk about that. It absorbs secretions to some extent. For example, if there is some sweating, maybe which is occurring inside the cast, okay, it may absorb that also a little bit. So it is considered as an advantage is there. It is fairly strong, and one of the very important point is it is radio translucent. Now radio translucent means I want to take X-ray after applying the POP cast, and I need to see the bone, I need to see the fracture site through this POP. If it is radio opaque, I cannot see the fracture site. So it has to be radiolucent, and it is radiolucent. So this is important point. Now, some of the disadvantages of POP are it is heavy and warm. Some of the patient may feel quite uncomfortable inside that cast area. It is unyielding, so it may cause pressure problem or uncertain immobilization. Pressure problem means it may give pressure to some of the area there. If it is a bit tighter, okay, and it may cause pain, pressure pain. After POP application, it is difficult to inspect the limb. So if there is some wound developing inside the POP cast, we may not see it, or we may not examine it properly. And it is not waterproof, so we cannot soak it in the water after we apply it. Okay, so we need to be careful. So these all are some of the disadvantages of POP cast. The one important point I like to highlight is if there is itching inside the slab, okay, of POP, that is very difficult to scratch, isn't it? Though we may find some small stick or something like that, we insert inside and do scratching, but still it is a bit difficult. Now, to avoid this disadvantages, they have developed certain other types of cast. Now, they are made up of polythene or plastazote. So these are alternative to POP cast, and these days they are quite popular as well. Now, because of the heaviness and ease of water damage, the newer casting materials have been developed. So what I am telling you right now is written here. Because of some disadvantages, okay, of POP cast, some newer concept have been developed. Means some other alternative form of casting have been developed, and these are polythene or plastazote. These are few of the examples. Now, how they act or how they work. Remember, in POP what we do, we soak that POP roll in the water, and after some time we'll apply it, and within around 15 to 20 minutes or within half an hour, it will get very hard. So similarly, in this situation, it undergoes a setting process. When activated by heat or water, it depends on the different material which is used for the synthesis of the cast. They all have slightly different characteristics, okay, but they have a good advantages over plaster of Paris, and that important advantages are they are light in weight, but they are very strong. They do not break easily. So what does that mean? If they do not break easily and if they are very strong, that means if we apply this type of cast, then patient can be able to bear weight, okay, quite early, which is a very important point in the management of fracture. See here, okay, let me underline this. Patient may be able to bear weight on an unprotected cast because of its nature, so that a physiotherapy is already started from quite early. Most of these materials are waterproof. This is another important advantage over POP cast. The main disadvantages of these new materials are they cannot be readily molded, and they are more expensive, much more expensive than POP cast. So it is a a matter of money now, and okay, they are not readily molded, means we cannot fold them easily. Okay, this is important point. Even after some of these disadvantages, okay, these new materials are becoming widely adopted, okay, and they are very commonly used all over the world. Let's move on. See here, okay. Now look at the different examples of these newer type of materials. Now see this, okay. This is not a POP cast. This is not a plaster of Paris cast. Okay, this is a different one. Okay, see here, this is like exactly look like a shoe actually. Okay, and this is another type of things which is made of a synthetic material. Some another picture. See here, it is not POP at all, but it is similar to POP. It is used to immobilize the fracture at this forearm area or the wrist area. This is another example of this. See here, okay. So these are the different pictures of external immobilization. Now, another concept in case of immobilization from the outside is known as cast bracing. Okay, this cast bracing is a hinged or jointed cast. So let me make it very easy for you so that you can go through these slides on your own. Actually, it's not very difficult to understand. If there is a fracture around the knee joint, lower end of the fracture femur or upper end of the tibia fracture, for example, then we need to mobilize our knee joint quite early. If I apply a big cast from the upper part of the thigh to the lower part of the leg, then that knee joint will not be moving. We cannot use that knee joint for a long time, maybe few months. Okay, this is not good thing. So if we apply the jointed or hinge or cast bracing, then okay, we can move the knee joint quite early. So what we do here, we apply the cast on the thigh. Okay, we leave a gap between the lower part of the upper cast and the upper part of the lower cast. That means the lower cast is applicable or applied on the tibia. So we leave a gap in the knee joint so that that joint can be used, and we have definitely some connection between the upper cast and the lower cast. So this is known as cast bracing. Now see here, some of the advantages of this cast bracing are the patient can bear full weight. Okay, patient can bear full weight in the beginning. Okay, and the device may be used both to secure reduction and then to hold the position. So this is used for both purpose. First is secure reduction and then to hold the position. But these days the use of this cast bracing is diminished because of interest in internal fixation. Internal fixation is surgery. We'll talk about that towards the later part of the class. Internal fixation is very commonly done these days. Okay, though it is expensive, people will choose for this type of modality because the fracture treatment will be done quite early here. Okay, the healing will occur quite early. So internal fixation has replaced cast bracing these days. But nevertheless, it is one of the options. Now, after talking about these different type of cast, let's go to the another way, okay, of fracture reduction and immobilization, that is called traction. Traction. Now see here, traction is pulling the bone directly or indirectly in order to reduce and hold the fracture. So directly or indirectly. So this is pulling the bone directly or indirectly, and why we do this? In order to reduce. This is for reduction and holding the fracture in that site, in that reduced site. This is important. So both for the reduction as well as immobilization, traction is important. Historically, traction has been a mainstay of fracture treatment around the world. So it was used from quite a long time. It is a technique used less often these days with the increasing use of internal fixation. Now again the same reason is there, because if we put traction in a fractured area, the patient will be fixed, isn't it? The patient cannot move properly. Patient will be immobilized in that particular setting, which is not desirable. But in place of that, if we fix the bone quite early as a help of surgery, okay, and with the help of surgery, then early mobilization can be achieved. So these are some of the important points. Now see here, let's go to the different methods of applying traction. Please pay attention, this is quite an interesting class, okay, and this is very useful for you regarding the practical knowledge as well. Now the first one is a skin traction. How we apply this skin traction? The force is exerted tangentially along the skin by using some adhesive strapping to attach the cord and the weight. So what they do, they put some tape on the skin, okay, and with the help of that adhesive tape or strapping, they will attach some of the weight there. That weight will constantly pull the bone distally, and that will act as a traction. That is called skin traction. So remember, you have just applied the adhesive tape or adhesive strapping on the skin, and with the help of that you have you have attaching the cord and weight there. Some disadvantages of this: if we keep it for a longer time, it may damage the skin. Okay, and another disadvantage is we cannot apply a large amount of weight on the skin traction. Probably around 5 kilo weight can only be applicable there. Okay, not more than that. And some of the people are sensitive to the adhesive tape as well. So for them, we cannot go for skin traction. The second one is a skeletal traction. Now, see here, look at this picture first, and it will be very easy for you to understand. So let me explain this. See this? This is tibia. This is tibia. Here is fibula. So there is a fracture at the shaft of tibia as well as fibula. So how the traction is applied there? For the reduction as well as immobilization. That is the purpose of giving traction. It is done by skeletal traction. Now look at this pin. This pin is inserted through the calcaneum. This is a calcaneum bone, or through the heel, and it has gone right through the bone, the calcaneal bone. Okay, and then you have attaching the cord there, and then certain weight is hanged here. This is the weight hanging, and with the result of this weight, this bone or the distal fragment of the fracture is constantly pulled downwards. Okay, which will help to reduce the fracture as well as for the immobilization. So this is called skeletal traction. So this is applied by means of a pin or similar device which is applied directly through the bone. It enables greater force to be used. Maybe around 10 kg can be kept very easily here, but it may allow infection into the bone. Quite logically, you have inserted a pin from outside. Okay, so there is a chance of infection, but this is one of the commonly done traction procedure all over the world. Now see here, another method of applying traction, okay, or another way of giving skeletal traction is a Gardner-Wells skull caliper, and this is used if we suspect cervical vertebra fracture. Cervical vertebra fracture, because cervical vertebra fracture is a serious type of injury. Okay, we should never ignore it because of the a chance of some complication. Now let me ask this question to you: what complication can happen if cervical vertebra is fractured? Yes, guys.
Spinal cord injury.
Good.
Paralysis.
Good. Very good.
Sir, let's see.
Damage to the vertebral artery may be there.
Damage
to respiratory tract.
Good. Good.
to the vertebral artery.
Very good.
At the level of C1 to C3, it can cause death.
Very good. So see that most of the answers I already got. Okay, now listen here, most of the answers are already given by the different students. Very good. So number one, it may cause the damage of spinal cord leading to quadriplegia. This is called quadriplegia or quadriparesis, because by that time brachial plexus has not come. Okay, and definitely lumbosacral plexus is way down. So all the four limbs, okay, will be paralyzed. This is called quadriparesis, number one. Number two, phrenic nerve is originated from that region, from the cervical part of the spinal cord. C3, C4, C5, phrenic nerve. If phrenic nerve is damaged, then there is a diaphragm paralysis. And another type of traction is known as sliding or balance type of traction. Okay, you can see this in the picture and understand it. In this condition, the patient's weight is balanced against an applied load. The patient's weight is balanced against an applied load. See this? There is a load which is applied here. This is the load, and here is the patient. Utilizing frictional and gravitational force to counterbalance the applied traction. So this is called sliding or balance traction. So it is used if a fracture occurs on the limb. Just the name is important here, okay? Now, there are some of the important types of sliding traction. One is called simple traction. The same picture which we just see is here again. This is the simple traction, which is an example of sliding type of traction. It is useful for many conditions, but particularly for those affecting the hip, because it is constantly applying the traction here. This is the counter traction which is applied by the patient weight, and then this part will be immobilized. Another type of sliding traction is longitudinal traction. Longitudinal traction. Now look at here. This is a traction force, okay, and the counter, okay, counter traction is given by the patient himself. So this is used, for example, for fracture of the femur. It is an alternative to the use of Thomas splint as a fixed traction device. Now Thomas splint is a type of splint. You have seen the picture before, okay? So it can be used as an alternative to Thomas splint. Now this traction is applied through a pin in the upper tibia, and the leg is supported on the Thomas splint with a special knee attachment, which is known as Pearson attachment, to allow the knee to be flexed. So what they do, this is a upper tibia. Remember, there is a pointed area on the upper part of the tibia, which is known as tibial tuberosity. So they may pass a pin through the tibial tuberosity and then apply the traction there. So this is the way. Another type of sliding traction is a very interesting one. This is called gallows traction. Gallows are also known as brine traction. Now look at the picture here. This is usually done, okay, in a child who are less than 2 years of age, and if there is fracture of the shaft of the femur, then usually the fracture is treated by this traction. So see here, this child's, okay, weight is, okay, acting like a traction here, and there is some counter traction which is given by this, you know, weight, and both of the lower limbs of this child who has a fractured femur is hanged here on the ceiling or on some area which is above. So this is a simple method of applying longitudinal traction to the femur in a child up to the age of 2 years. In older children, vascular complication may occur, so we do not go for this. And the traction is arranged to raise the buttock just clear of the bed, then only it will be effective. If the buttock touches the bed, then, okay, the traction and counter traction would not be sufficient. So this is not going to help the child. So gallows traction, please remember this picture. These days, this type of questions are very commonly asked in the exam. Now with this different type of traction, let's go to the last important part of fracture immobilization, which is known as internal fixation. These days, okay, in this modern world, the fracture management is mainly done by internal fixation, especially if there's some complicated type of fracture. If patient wants to mobilize quite early, then internal fixation is done. Soft tissue heal better with a stable and reduced fracture in case of internal fixation, and they are getting more popular because of the different advantages. Now see here, fixation is necessary for those fracture where accurate reduction is necessary and when mobilization of the limb or the patient is particularly important. The same thing I'm explaining here. If patient wants to mobilize quite early, okay, if patient wants to mobilize the limb, if there is a fear of deep vein thrombosis, okay, for example, there is a risk factor for thrombosis in the patient, then most of these patients are treated by internal fixation. Accurate reduction is essential for fracture involving the joint surface when you are treating with internal fixation. Otherwise, there may be some problem regarding the continuity or congruity of the joint. Later on, they may suffer from osteoarthritis. So this is important one. Internal fixation can be used, but with more danger due to infection in open fracture. Now, it is quite logical, isn't it? In open fracture, there is no skin. Probably there is no soft tissue also. Some muscle mass is already lost. The fracture site is communicating to the outer environment. So if we put internal fixation device there, there is a high chance of infection there. So in this type of situation, we treat by external fixation. External fixation is commonly used. We'll talk about that later. Now, I want you to focus on this slide on your screen. Look at these different, forms of internal fixation device. They may be screws, they may be plate, they may be compression plate, or they may be intramedullary nail. Now, I am going to show you, okay, with the help of a pointer, and you tell me what are these. Can you tell me what type of internal fixation is this? Yes, this one.
Intramedullary.
Rod.
Exactly. You can say intramedullary rod or intramedullary nail. Absolutely. See that? Okay. There is a big rod which is kept right in the medullary cavity. Okay. And this is a tibia. This is a tibia bone. I can see the ankle joint here. Okay. Tibia is a big bone, a long bone. So it can be treated. The fracture can be treated like this. Look at the fracture site here. It is right here in the shaft of the tibia. Okay. So this is one of the excellent way of treating. To make this rod immobile in place, okay, some screws are applied. See there, one screw distally, okay, and two screws at the top. This is called application of a screw, okay, a cancellous type of screw, and this is a malleolus. This is called lateral malleolus. This is a medial malleolus. So you can clearly see here, this is used for the treatment of malleolar fracture in this case, and this is again a plate with the screws, plate with the screws, and this is called dynamic, okay, dynamic or compression plate. It will compress the fracture site. Internal fixation devices allow a degree of flexibility at the fracture site. Definitely it will allow a degree of flexibility at the fracture site, and slight amount of movement is also possible. One of the very good advantage of internal fixation device is if there is some soft tissue injury, we can also manage that side by side. Just think about it here. If you apply a plaster of Paris cast at the fracture, and if there are soft tissue injury, that will be disastrous. We cannot manage that soft tissue injury at all, and during that time POP cast is also contraindicated. Okay, but internal fixation can be easily done. It should be done by minimal soft tissue dissection, thus preserving as much blood supply as possible. This is a very important point. If you damage the blood circulation or blood supply at the fracture site, the fracture is not going to heal. So very minimal soft tissue dissection should be done when you apply internal fixator. Now, let's talk about some of the advantages and disadvantages of internal fixation. So please pay attention here. All of you, please have a look there. What are the advantages of internal fixation? Internal fixation allows accurate reduction and maintenance of position. Definitely. That's why it is hugely popular these days. Though it is expensive, people, they don't care about money when it matters the comfort and the time. Okay, money is secondary during this condition. It allows the patient and his or her joints more mobility, thus encouraging rehabilitation and avoiding the joint stiffness. So it will allow more mobility than the POP cast. And when the patient are mobilizing their joint, it will encourage rehabilitation and definitely avoid the stiffness of the joint, which is one of the important problem after fracture. Another important advantage is it may encourage union of the fracture, okay, union of the fracture. And another advantage, it diminishes time spent in the hospital. Definitely, the patient can be discharged quite early than in other cases. Patient can mobilize early, so everything is faster, okay, and better in case of internal fixation. But there are certain disadvantages also. Everything has advantages and disadvantages, okay. So you explain these things to the patient and then they decide whether they want to go for this or not. Never force or implement your idea on the patient. Never do that. You give counseling to them. You explain what are the advantages and disadvantages of each of these methods, and then they will choose what they want to do. Then you do accordingly. This is the principles of therapy. So the disadvantages are, it may introduce infection because this is a surgery. You are going to give the incision there. You are going to put the internal fixation device which is attached to the bone. Okay. So if the whole procedure is unsterilized, it's a big problem happen. That is infection. Operative complication may occur. Complications of anesthesia, excessive bleeding, those things are always there. If it is adequate or if it is inadequate, or infection occurs, union may be long delayed or may not occur at all. So see there, especially if it is inadequate, means if it is improperly done, you have done but not completely, or if somehow infection occur, then the fracture will undergo into non-union or delayed union. It may not be sufficiently strong to allow the advantages of full mobilization. You have to put the plate, but you have put the screws there. That those screws are not stronger than the plate. So that is one example we can give here. If there is very rigid type of fixation, and if there is a periosteal stripping when you apply the internal device, it may delay the union. Now let me ask you one question here. Why periosteal stripping may cause delay union? What's the reason? Yes?
Low light.
Blood vessel may be damaged.
Good, very good. Blood vessel may be damaged because there are a lot of blood vessels in the periosteal area, and the bone on the outer aspect is getting blood supply from these periosteal blood vessels. Another point, there are some active cells also. These cells are called a pluripotent cell. Okay, they can transform into any other type of cell during the fracture healing. So these are the two important reason you can give here. Another one, this is also considered as a disadvantage. Further surgery may be needed to remove the device later on, and many of the patient, they want those device to be removed, and somebody may be happy with the device through the rest of their life. So it depends on the person, but usually it is removed and second surgery is necessary. Now let's move further. Now let's know about some of the techniques of internal fixation. The first one is screw fixation. You can clearly see here in the picture. This is a cancellous screw because this is a cancellous bone. So this type of screw is applied on the fracture site. See there, this is fibula. Okay, this is the lower end of the fibula. We call it lateral malleoli. This is tibia. This is called medial malleoli. This bone is called talus, and this is calcaneum. So So you need to know the names of the bone in orthopedic, okay? If you do not, please revise this. So fibula, tibia, talus and calcaneum. This is lateral malleolus, this is medial malleolus. So you can see here, there is a fracture, okay? There is a fracture line here. So this is very nicely treated by a cancellous screw. Now this is another picture. See there is a fracture line, you can clearly see, and this is a screw fixation. Now this is called compression screw fixation, because at the same time it is giving pressure or it is giving compression along with fixation. So compression screw fixation, okay? So it is another example of screw fixation. The third one is a plate fixation. A plate. Now see there. So let me use the pointer here so that it will be easy for you. See here. So these pictures are very informative. So this is a plate here. This is a long plate which is applied, and these are the screws which should be there to fix the plate on the surface of the bone. There is a fracture line here, you can clearly see. Okay. If this type of plate gives compression to the fracture site, we call it dynamic compression plate. You see this, I can still see a big gap here, but I cannot see that big gap in this picture because it is getting compression from either end. So this is called dynamic compression plate. So these are the different examples of plate fixation. This is a very good way of treatment of the fracture. Another one is an intramedullary nail. Now in the last class also we talked about this. See there, have a look here. This is a intramedullary nail, okay, a long device, and at the ends of this device it is fixed with screws. See there, okay, it is fixed with screws. So this is a intramedullary nail. So which bone is this? Every student know. This is tibia. You can clearly see this is tibia. Tibia is an important long bone in our body. It is a weight bearing bone. So a femur, okay, tibia and humerus. If there is a fracture at the shaft of these three important bone, we can fix this by intramedullary nail. Now let's talk about this a little bit. This technique involves the passage of a rod into the medullary canal of a long bone and across the fracture site. If you see it very carefully, you can see here is the fracture line in this area. Okay, here is the fracture line. So this nail or rod crosses the fracture line. Okay, and it is nicely staying at the medullary cavity of the bone. With modern design, these can be introduced distant to the fracture site and through very small incision. This is a big advantage of intramedullary nail. Now, what are they saying here? You don't need to make any incision at the fracture site. You don't need to expose the fracture site. Rather than that, you can make a very small incision either, okay, on the lower end of the bone or upper end of the bone, and through that you can insert this intramedullary nail and fix it as well. This is a big advantage over a plating. Now, what is the advantages of locking of these nail? Okay, every orthopedic surgeon, they don't want to lock the nail, but many of them want to do. Okay, so what is the advantage of locking this nail? So see that this is a locked intramedullary nail when you apply some screws at the ends. Rotation at the fracture site may happen if we do not lock it. Okay. If medullary canal is large, then this nail can rotate inside the medullary canal. So to overcome this problem, we apply screws towards the end, and this is called locked intramedullary nail. let's talk something more about this intramedullary nail. Now see here, the long bone fractures in multiply injured patients are best managed by early stabilization, and nails are often used for this. I already told you which are those fractures. Those are femur, tibia, and humerus shaft fracture. So fracture of the shaft of the femur, fracture of shaft of the tibia, and fracture of the shaft of the humerus. They are very well managed by intramedullary nail. Don't forget that. These are the important take-home messages from this long class. Infection following intramedullary nail is usually more difficult to treat than with other methods of internal fixation. I already told you this. Whenever infection occur in these devices, remember that you need to remove the whole device. You need to remove it. Okay, allow that infection to treat or heal, and then reapply again. Now, this is a big problem for the patient, isn't it? Patient need to suffer. Patient need to undergo so many different surgeries. So we need to be very careful in the first time itself. The same thing is written here. Okay, this is called exchange nailing. If you treat the infection and reapply the nail again, this is called exchange nailing. And intramedullary nail is mainly used for fracture of the femur and tibia as well as humerus. Now, after talking those intramedullary nail, what is the use of wire? Okay. These wires are some other method of internal fixation. Now, see here, please. Now, look at this picture here. Okay. So, which bone is this?
Ulna.
Very good. This is ulna. So, how you identify this is ulna? Yes. What is this process?
Olecranon process.
Olecranon process. Excellent. This is olecranon process. Very good. Okay. So, this is ulna. So, see there is a fracture of the olecranon process here, and this fracture is very well managed by application of the wire. Even patella fracture, patella can be managed very well by this wire. So these are occasionally used to hold bone fragments in position. These are called stiff Kirschner wire. In orthopedic, we call them K wire. Okay, K is the short form, and this is Kirschner wire. It is also used for Colles fracture or as a figure of 8 tension band in case of olecranon or patella fracture. So in this picture, there is a olecranon fracture shown, but patella fracture and even Colles fracture. Colles fracture is fracture of the distal end of the radius bone. It's a very important fracture we are going to talk later on. All of these can be managed by wire application. Now, after dealing with this internal fixation device, let's talk about what is the use of external fixator. Now, please pay attention here. Now, see this. So, these are the frame fixation. Frame fixation is an example of external fixator device. So, sometimes what happens, the fracture is very bad with a lot of soft tissue injury as well. So, during that time, a lot of contamination is also suspected. It's a type of open or compound fracture. And remember, during that time, you cannot immediately put internal fixator device because you are afraid of infection there. And I already told you, if infection occur after you put internal fixator device, okay, it is a disaster for the patient. So in that type of situation, you treat the fracture by external fixator device. So in this condition, the main part of the device stays outside, like this you can see in the picture. Only the screws and the nails are kept inside. At the same time, see there, the soft tissue injury can be very well managed because nothing is, isn't it, obstructing it. So this is the principle. Now let's talk about it. There are situations where external splintage using plaster of Paris or traction may not be adequate or may have other disadvantages. But on the other hand, internal fixation may be hazardous or technically impossible. That's what I am explaining just now to you. These are very important example in compound or open fracture, or in case of comminuted fracture, for example, there are multiple pieces there. In this condition, external fixation is a wonderful choice. So we go for external fixation and we insert pins or fine wire into the bone above and below the fracture and connect these together rigidly by means of a frame assembly, exactly like this. You can see in the picture. See this is a frame assembly. Okay, so all of these are connected together on outside and some pins are inserted inside, either above or below the fracture site. So this is called Ilizarov technique, also known as circular frame. Now let's talk something more about it. They have the advantages of giving good fixation, okay, while they also allow the access to the fracture site. If there is a large skin, okay, large part of the skin which is damaged, or large part of the soft tissue is damaged, we need to take care of that wound. You cannot cover that wound by plaster of Paris. During that time, this frame fixation is the wonderful option. They also avoid the danger of introducing foreign material into the fracture site, and that's what I was talking. Internal fixation may be dangerous during this type of situation, so we go for external fixator. Now they can be of a different type: monolateral fixator and circular frame. The circular frame you have already seen the picture. So if there is only one bar on one side of the bone, and through that bar multiple wire or pins are inserted, okay, above the fracture and below the fracture, we call it monolateral fixator. Monolateral fixator, the name itself is telling you the meaning here. Okay, see this, monolateral fixator. And circular frame is a frame all around or on the circumference of the bone. Angular deformity and limb shortening can be managed by the use of external fixator. So this is another use of external fixator for the treatment. Please mute yourself. I can hear some noise there. Now see here, look at this picture. See this, okay? This is the circular one, isn't it? Very easy to understand, a circular type of frame. This is example of external fixator. This is called monolateral external fixator. There is a bar on only one side of the bone, and this bar stays outside, and through this we have inserted different pins above the fracture site and below the fracture site, so that this fracture is stable. So this is a perfect picture of external fixator. Now we have come towards the end, okay, of this important topic. At the end, let's revise some of the key points. So I want all the students, please pay attention here. This is like a summary of this whole topic. Fracture fixation should be used in the following situations: when adequate reduction cannot be maintained by external splintage, especially if the fracture involves the joint surface, then okay, fracture fixation must be done. Another reason, okay, wait. Another reason, when it is important to allow the early movement of a limb or a joint, fracture fixation is a good option rather than plaster of Paris. And third, when it is important to avoid a long period of immobilization in the bed, after internal fixation, we can quickly mobilize the patient and all the problems associated with immobilization, importantly deep vein thrombosis and pulmonary embolism, can be decreased. A good example of this type of fracture are femoral neck fracture in elderly patient. Remember, this fracture is not heal or will not heal in time because of problem of osteoporosis in elderly people. So we have to go for internal fixation in this type of fracture. Another reason or important key point would be in cases of multiple trauma, where internal or external fixation of one or more of the fracture may simplify the treatment of other injury and has been shown to reduce the mortality, you can go for internal fixator. In multiple trauma, either external or internal, both can be done according to the situation. A fracture which is associated with severe vascular injury and that blood vessel injury require repair, we have to go for surgery now, and for that surgery you need to open that fracture site, you need to explore it, which blood vessels is damaged, you need to repair it, and at the same time you can go for internal fixation. This is another important key point here. And certain pathological fracture, okay, certain pathological fracture, or I want to extend the things here, most of the pathological fracture, they need internal fixation for the union, because the conservative management usually fail in pathological fracture. Why? Because the bone is already diseased, it is not a normal bone, the healing process is already very delayed there. So these are some of the important key points. Now another question, how long should fixation be maintained? Isn't it? After we apply that fixation, how long it should be maintained? Now see here, fracture vary in length of time needed for the union, and a general principle for this is most fracture of the shaft of long bone in adult take at least 12 weeks to unite. 12 weeks in the long bone fracture, 12 weeks means 3 months. So this is a general time. And fracture in the cancellous end of the long bone and in short bone takes from 6 to 8 weeks, almost half of that time required. If we go back and remind ourselves about the fracture healing topic which we done a little while before, in our bone, okay, near the end of the bone there are cancellous bone, and at the shaft of the bone there is cortical bone. Cancellous bone heals much better and earlier than cortical bone. So this is the same principle is applicable here. In children, the times are proportionately reduced with the age down to 2 to 3 weeks for a fracture of the shaft of the long bone in a baby. So 2 to 3 weeks would be enough in case of children. Wow. Whereas in case of adult, see there, it's 12 weeks. If fixation has been used simply to relieve the pain rather than to hold an unstable position, it will usually be possible to discard it after 2 to 3 weeks in an adult and less in a child. So in the beginning of this management of fracture class, we talk about external splintage, and one of the principle of application of those external splintage is to relieve the pain. So if that is our purpose, then we can easily discard it after 2 to 3 weeks. The last part of the fracture management is rehabilitation. You should never underestimate, okay, the role of rehabilitation. Now, what is the meaning? Let's talk about it a bit. This begins immediately after the primary treatment of the fracture. Okay, the patient try to move around so that the muscles will not become stiff, joint will not become stiff. At the same time, the fracture is immobilized. the limb is moved and used as much as the method of fixation allow. If we have done internal fixation, it is much easier and much earlier. This helps to stimulate the union and to prevent the joint stiffness. Now remember one thing, if the patient start to bear weight, okay, up to a certain level, it will stimulate the fracture union, and if the patient moves around, it will prevent the joint stiffness. This is called physiotherapy or rehabilitation, and it has to be explained to the patient. If you say you need to stay on the bed all the time, patient will not move around. So it is your job to tell the importance of these things to the patient. Internal fixation has a great advantage in this respect because it is quite secure type of thing, but you have to put a proper internal fixator device there. I already told you this. If it needs a big plate or a long plate with a lot of screws, we need to go for that rather than putting 1 or 2 screws there. That is unsecure. So if it is a really secure and stronger type of internal fixation, it has a great advantage regarding rehabilitation. Patient can return to his or her normal occupation in case of internal fixation quite early, okay, and when splintage is discontinued, a further period of exercise or physiotherapy is often necessary before full joint function is restored. Now let me tell you my own experience. Okay, a long time ago, probably around 10 years ago, I also suffered from fracture lower end of the fibula. Okay, so I the doctor put the POP cast, okay, POP cast on me for 8 weeks. Okay, for 8 weeks. Now remember, there's a lot of disadvantages of plaster of Paris cast. I already explained to you. So I was like, I needed to get rid of that plaster of Paris cast as soon as possible during that time. So I went to the orthopedic surgeon after 8 weeks. He took the X-ray. Again, X-ray showed very good callus formation there. So he took the chance and cut the cast and asked, for the good physiotherapy. But the first week after I removed the cast, okay, I could not, bear the weight. It is so much uncomfortable there. So all these things, okay, will slowly be resolved by rehabilitation or physiotherapy. So this is such an important part of the fracture management. Now, this summary, I don't need to, go into, detailed explanation regarding this. Every student can go, or study this on their own. See there, any type of, serious injury or multiple fracture, we go for ABC management. And in the next class, or at 10 a.m. class, I'm going to talk about advanced trauma life support, and the same thing will come back there again. Okay. Check the history of allergy, medication, past medical history, last meal taken, what time the person took the last meal, and what are the events surrounding injury. These are the very important point when we take history in a orthopedic. Okay, so let's continue. We're talking about the summary of the last topic, that is general management of fracture. Very, very important one. You can expect a lot of questions from this topic in your exam and written exam as well as viva exam. Now, if there is history of only minor trauma and that is causing fracture, then we think this is a pathological fracture. Minor trauma or trivial trauma, and which can cause fracture easily, that has to be pathological fracture. There are so many causes for pathological fracture. Let's not go into detail now. This itself is a important topic. Analgesia should be provided, okay, in a good amount to the patient because it is a very painful condition. And which analgesic you like to give in case of fracture? Which are those analgesics? Yes?
Sir, ketamine, lidocaine.
Okay.
Good, good. Lidocaine, ketamine, very good. These are, one is general anesthetic and another is local anesthetic. Okay. Now, another type of painkiller also you have to give. Those painkiller are same, NSAID drug. NSAID or orally active opioid drug. This has to be given, for example, 8 hourly or 6 hourly in a day for a few days time, because this is a painful condition. But when you do some manipulation there, you have to give analgesic, either general or local. Imaging, that is X-ray. These days CT scan is also very commonly done. X-ray and CT scan has to be done of that fracture site, and make sure what type of fracture is it. Splint extremity is important. There are so many advantages of the splintage. One is to decrease the pain, another is to improve the function. Third one, if there are some nerve damage, blood vessel damage or soft tissue injury, it also helps not to extend the injury further by splinting. Now this is the summary of the whole topic what we discussed here, very nicely presented. First is obtain the reduction with appropriate IV sedation. Most important drug is ketamine here. But if you choose a local anesthetic at the fracture site, you can give some additional type of other drug like morphine. Okay, morphine can be given along with the local anesthetic. Morphine will sedate the patient. Now, first is close reduction, and this close reduction is done by application of the traction in the long axis of the limb, skeletal traction, skin traction, sliding traction, gallows traction. These are the different examples. Reverse the mechanism that produced the fracture and reduce with IV sedation and muscle relaxation. Fluoroscopy can be used if available. So this is the way of close reduction, also known as manipulation under anesthesia. Now, these are the indications for open reduction. Open reduction is a type of surgery. So we all know that. So which are the indication? One, if the patient is not opting for cast, if the patient say, I don't want any cast on my limb, go for open reduction. Other indications include failed close reduction. We have tried close reduction, but it failed. Non-union of a fracture, okay, open reduction and internal fixation is the best choice. Neurovascular compromise, of course, we need to see exactly what is happening there, okay, manage it, and then fix the fracture site by internal fixation. Not able to cast or apply traction due to site, like hip fracture. We don't put any cast on the hip fracture because there is no place to put the cast. So you need to go for open reduction and internal fixation. Intra-articular fracture, which is known as Salter-Harris fracture. So these are best managed by open reduction and internal fixation again. Pathological fracture and polytrauma, open reduction is done. Pathological fracture, remember, there is very, very less chance of fracture healing if you go for conventional management. So open reduction, internal fixation is usually done. Potential for improved function with ORIF. ORIF is open reduction, internal fixation. So if the patient wants to resume the activity very soon, if the patient wants to go to office very soon or school or wherever, then open reduction and internal fixation is indicated. Okay, always recheck the neurovascular system after reduction and obtain post-reduction X-ray. So neurovascular system should be examined. Now, after reduction, maintain the reduction or immobilization. So every student probably know a lot of things now about this. It is done by external stabilization like splinting, cast. This cast is mainly done by POP cast or even by some synthetic cast these days, okay, other than POP, traction and external fixator. It may be monolateral external fixator or circular one. Internal stabilization can be done by pin Extramedullary fixation can be done by screws, plate, wire, or intramedullary rod. Okay, so all of those things we recently talked. And repeated follow-up is necessary to evaluate the proper bone healing. And finally, okay, just like we always say, last but not the least, don't forget about physiotherapy or rehabilitation of the patient. Absolutely important. You have treated the fracture wonderfully well, but if you do not rehabilitate the patient, then there will be persistent joint stiffness and patient will lose the function of that limb, or it will take a long time to regain the function. So this is how fracture is treated. Remember, this is just a general discussion. Later on, when we talk about individual fracture, okay, the appropriate management of those individual fracture will be talked once again.